article pinned. Would you please just pin it, Viviana?
Yeah, sure. Just give me. Okay, so I will be pinning the article shortly. If Madhuri, if you want to proceed in the meantime, feel free to do so, of course. Madhuri, if you want to proceed in the meantime, feel free to do so, of course.
Hello, and welcome to MedNews Week Conference, where our goal is to bring you the most cutting-edge information from medicine's global leaders. I am Muskan Joshi, and I will be your host for today. Before we begin, I want to first acknowledge the great team that helps make these events a reality. Our founders are two internationally recognized researchers, Dr. Jan Leifman and Dr. Chandler Park, who is also the president of Kentucky ASCO. Our chairs include Dr. Park and Dr. Leifman. Our associate directors include Madhuri Balasubramaniam, Gayatri Menon, Helena Koloma, and myself. Our associate managers include Alexandra Vandekaev, William Wilkerson, Ahmad Aziz, and Viviana Cortiana. Our educational committee consists of Sean Jakevitz, Choya Harshal, Shri Vallabhaini, Soumya Nadar, Rabab Huned, Imad bin Zahid, Shrivika Kannan, Gabriel Alves, Diksha Mahendru, Jana Ghazal, Sukhmani Sidhu, and Blaise Bowers. We would also like to thank our partners, WUMEDI, who is a global leader in medical video educational content, the National Society of High School Scholars, an honor society founded by the class Nobel of the Nobel Prize family, I3 Health, which is a CME, NCPD, CPE accredited organization with the mission of enhancing the proficiency of the multidisciplinary team by providing evidence-based activities that address unmet educational needs for the healthcare team. Oncology Advisor is I3 Health's new website that helps deliver up-to-date, clinically relevant content, interviews, and commentary from key opinion leaders in oncology. MDPI Cancers, an international renowned research journal which provides the latest developments in the field of oncology. The moderator for today's event is Viviana Cortiana. Now to introduce our wonderful speaker for the day, Dr. Amer Zeidan. He is an internationally recognized leader and researcher in hematology and oncology. He has worked on more than 75 clinical trials for innovative therapies for myeloid leukemia and malignancies, myelodysplastic syndrome, and patients undergoing chemotherapy. He has held multiple leadership positions, including the chair for Protocol Review Committee, leader of the Myeloid Disease and Leukemia Aligned Research Team DART at the Yale Cancer Center, director of the Early Therapeutics Program and Continued Medical Education Hematology Section at Yale University, and the director of the Myelodysplastic Syndrome Center of Excellence at the Yale Cancer Center. He is also the recipient of various national and international honors and awards, including Leukemia and Lymphoma Society Scholar in Clinical Research Award, National Cancer Institute Cancer Clinical Investigator Team Leadership Award, and the Young Investigator Travel Grant from the Society of Oncologic Malignancies SOHO's annual meeting in Houston, Texas. He is also the recipient of more than 11 grants from various acclaimed organizations such as the American Society of Oncology, National Institute of Health, Leukemia and Lymphoma Society, and the Yale University. He is a globally acclaimed speaker who has given more than 180 presentations all over the world, and with over more than 280 peer-reviewed research publications, 7 book chapters, and more than 260 poster presentations for widely recognized organizations such as American Society of Hematology, British Society of Hematology, European Hematology Association, and many more, Dr. Zeidan is at the forefront of research in hematology and oncology. With that, it is my due pleasure to welcome Dr. Amer Zeidan. The floor is all yours.
Yeah, many thanks for the kind introduction, and it's a true pleasure to be here with you today. So I'm sharing my screen, and I will be talking to you today, as you can see, about myelodysplastic syndromes with a particular focus on some of the novel therapies, as well as efforts that I have worked on in terms of immune checkpoint inhibition in particular. So I think you can see right now the screen in the, hopefully not in the present. Let me see. I don't think you have it in the presenter mode. Okay. So these are my disclosures. The outline of what I will be talking about today is updates in classification, risk stratification, and response assessment in MDS. Then I will cover what is current and what is investigation in terms of management of lower risk MDS as well as high risk MDS, and finally talk about some of our efforts in the immune checkpoint inhibition front in MDS and AML. So many of you might know this, but myelodysplastic syndromes are cancers. This is why they have been named myelodysplastic neoplasms by the WHO in the year 2022, finally. However, they are very heterogeneous, and they are characterized by a clinical course that could vary in terms of expected survival of decades in patients who have mild cytopenias without significant progression, all the way to a process that looks like acute myeloid leukemia. There is a variable risk of progression to also aggressive course such as acute myeloid leukemia, but all MDS are characterized by some degree of cytopenia related to ineffective hematopoiesis. They are generally rare, and they are under-recognized and under-diagnosed. The number of cases in the US is around 4 per 100,000. There are 20,000 cases a year, and they tend to happen in older patients in their early 70s, which creates a number of problems in relationship to management, especially with aggressive therapies, because those patients often will have comorbidities and other medical conditions. I think importantly also, most patients have idiopathic MDS, meaning that we do not know why they developed MDS, but some patients do have family history or epidemiological factors, for example, in addition to age, being a male, being a smoker. Certain exposures such as chemicals and solvents have been associated with development of MDS. And as I mentioned, myelodysplastic syndromes are cancers. It's important to remember that because they often are called pre-leukemia or an anemia or a syndrome, but they are indeed cancers. And when you take all the patients together and look at their 5-year survival, it's actually not that much more than acute myeloid leukemia. The 5-year crude survival is around 31% compared to 24% with acute myeloid leukemia. And this is much worse than some of the more common tumors, such as kidney and breast and prostate cancer, when you take all the patients diagnosed together, regardless of the stage. And we also understand that there is a number of conditions that predispose to the development of MDS, but also importantly could be related to other clinical conditions such as inflammation related to atherosclerosis, coronary artery disease. And it's really a syndromic situation where multiple organs are affected. And this continuum between CHIP and what is currently called CCAS, which is cytopenia that has clonal abnormality but does not have the dysplasia that qualifies it as MDS, or the cytogenetic abnormalities that define MDS. And many places, including here at Yale, we have CHIP-focused clinics led by Dr. Lourdes Mendes. For us at Yale, focusing on those patients who have these clonal abnormalities before the full-blown development of MDS. Why is the clinical course of MDS is very variable? Part of this is related to the wide genomic heterogeneity of the disease. And as you can see here, there are more than 40 recurrently abnormal somatic mutations that occur in patients across different pathways, including transcription signaling, as well as epigenetic modulation with chromatin modification and DNA methylation. And those are widely dispersed. So there are only 6 of them that happen in more than 10% of patients. And the average number of mutations in any particular patient is 2 to 3 mutations. And therefore, development of therapies that work for all patients with MDS generally has been quite challenging. And another piece, I guess, that makes the management of MDS more challenging is the different subgroups. So there are subgroups of the disease that vary widely in terms of the clinical behavior. For example, patients with refractory anemia, where they have isolated anemia, one of the most common forms of MDS, those patients can have an indolent course and the anemia could be mild, but most patients will have progression and they will need transfusions. While there are more severe entities such as MDS with excess blast 2, where the behavior could be very close to acute myeloid leukemia. And you can see here in this figure the evolution of how these entities, subgroups were separated and then changed over time. And most recently, in the year 2022, we had the 2 new classifications. In addition to the WHO, we have the International Consensus classification. Both of those classifications emphasize the genetic assessment and use things such as TP53 and deletion 5q, as well as SF3B1 to classify patients with MDS, but they have significant differences. And those differences could lead to problems in terms of counseling patients and in terms of clinical trial enrollments and drug approvals and regulatory review by the agencies, etc. So we have been actually working across the international consortium of MDS, which is a large international think tank of global leaders in MDS across the world, trying to tackle important issues that impede progress in MDS, especially in terms of therapeutic drug approvals. And one of those was the divergent classification schema. And under the auspices of the International Consortium of MDS, we have compiled a large database of more than 7,000 patients from the US and Europe that has extensive biological and molecular and clinical annotation of data to try to come up with a data-driven roadmap for a harmonized classification system. This work has been presented more than once now, and actually there will be an update on this in ASH to try to kind of lead us, hopefully, towards a harmonized classification in the year 2024. The next important step once you diagnose and classify MDS is the risk stratification. Why is that important? Because as I mentioned, patients could have very different clinical outcomes. Some of them have severe disease, some of them have more indolent disease, and there has been different prognostic tools used to do this classification. IPSS was the original one, has been used since the 1997 when it was first published. It was revised in the year 2012. In the interim, other prognostic tools such as the WHO and the MD Anderson and other risk groups have been shown. All of these risk groups will depend on the blast count, on the karyotypic abnormalities, as well as on the blood counts to classify patients into either lower risk, which what you see in green, or higher risk, which is what you see in red. And this is important to counsel patients and to discuss therapies, but I think there are certain problems with these tools. The most important one, that they do not account for comorbidities. They focus on disease-related factors, not on patient-related factors, and they are not intended to predict benefit from any particular therapy. And the prognosis that you get out of them is a group prognosis for patients who belong to that risk category, and not an individualized prognosis. And finally, and importantly, they do not account for the molecular alterations, which we know carry important independent prognostic value. We have known this for the last 10, 15 years, and there has been a lot of work to incorporate molecular assessment into formally into risk stratification for MDS. And just to add more to this, for example, we knew that patients with lower risk MDS, many of them were not really lower risk, because around 1/4 of patients who are called lower risk MDS by the IPSS, for example, would die within 2 years. And again, that emphasizes the fact that additional improved stratification tools were needed. And we also knew that patients, for example, with therapy-related MDS overall had worse prognosis, but for a long time, some people have referred those patients for transplant as a group, anybody with therapy-related MDS. And the number of those patients have been increasing because we have more long-term survivals from chemo. But importantly, these patients actually also have different prognoses. And patients, for example, who have therapy-related MDS, who have a lower IPSS, like low and very low, they actually have a survival that can be up to 5-6 years. So not all of them will need to go to transplant. And this is important to remember. So as a group, these patients do worse than those with de novo MDS, but there's significant variation, and those should be risk stratified and counseled and managed according to the risk group. Importantly, last year, another important development was finally the publication of the molecular IPSS, which incorporated the molecular assessment formally into the risk stratification of patients. So the molecular IPSS uses 31 genes, and among those, there are 17 genetic variables from 16 main effect genes. You can see them listed in this figure, and the paper was published in the New England Journal of Medicine Evidence by Bernard et al. And it uses one genetic variable from 15 residual genes, and then you add that to the clinical parameters that we discussed, the blood counts, the blast count, and the karyotypic abnormalities, and then you get stratified in one of 6 groups this time, where patients again could range from very low to very high risk, and you can see the median overall survival as well as the median leukemia-free survival, which is significantly different between these groups. And what all of these prognostic tools are doing is that they keep increasing the risk stratification status of patients over time from lower to high risk, meaning that there are more and more patients who are being stratified with these novel tools, such as the IPSSM, to higher risk. And this is an example of these shifts. This is a large data pool from combined analysis from Stimulus MDS1 and MDS2, looking at the baseline characteristics. More than 600 patients were enrolled in these trials. And you can see here readily that the patients who are risk stratified as very high will go, the number of them will increase with the IPSSM compared to the IPSS. And this is something that has been seen in other data sets. So there are more and more patients who have more advanced disease according to the new risk tools, but a lot of questions remain about how do you manage those patients. And the last thing I want to talk about before we go to the therapeutic considerations is the response criteria in MDS. So response criteria in MDS have generally or historically been, in my opinion, one of the reasons why we have a lot of therapeutic failure in MDS, because they have not been very good at selecting drugs that should move from phase 1 to randomized phase 3 trials. And that led to a number of drugs being described as promising in phase 1 studies, but once they go to the phase 3, they fail. And there are several reasons for this. I'm not going to go through this issue in detail because it has a lot of technical considerations, but I'm happy to discuss afterwards in the question Q&A. But one of the important problems in those response criteria that are used in high-risk MDS, for example, is the introduction of marrow CR, which is having a blast count of less than 5% without count recovery. This was introduced in 2006, and I think, again, it led to drugs kind of being called promising when they are not. And because of that and multiple other problems with these response criteria, the 2006, I am listing them all here, where they could both underestimate and overestimate the therapeutic benefits of therapies, but importantly, they also lack clear guidance on the practical considerations in terms of application, interpretation, and inter-observer reproducibility, meaning that if I give the same data set to more than one person, they would come up with different response rates using the same criteria, just because they don't give clear guidance on when do you look, for example, at the blood count. Do you do it at the same day of the bone marrow biopsy? Do you do it a week later, 2 weeks later? What if the patient had transfusions? And also, if the patient has MDS IP2 with 10 to 19% plus, do you classify this person as, or do you use response criteria for MDS or AML? And because of all of these factors, we have combined a large international group to look through these, and we developed the International Working Group response criteria for 2023, focused on high-risk MDS. And this proposal has been published in Blood 2023. For those of you who are interested into going into the details, this was a very long process, took over 2 years. Started with a systematic review to look at all the data related to association between short-term response criteria and long-term outcomes. And then we had a meeting of the core group where we reviewed all the results, and then we developed a consensus process where we had more than 35 experts from all over the world to kind of go over these data. And then we developed a modified Delphi process to establish consensus with a high level of agreement on what responses basically make for clinically meaningful responses. And we underwent multiple rounds of voting to establish consensus. And finally, those guidelines were updated and published in Blood 2023. This is a summary of the changes. Again, I am not going to go through all of these in terms of technical issues. The paper is very detailed and has all the information, but we have eliminated marrow CR and stable disease as a formal response criteria. We redefined complete remission using a lower hemoglobin threshold of 10, emphasized that the blast count has to go less than 5%. We also introduced less than CR responses, which are reductions in the blast count to less than 5% coupled with meaningful count recovery. And there are two entities under this, which are called complete response with limited count recovery and complete response with partial count recovery. And we also clarified issues related time to event, such as how do you define event-free survival. We also emphasized the practical aspect and ensuring reproducibility by providing very clear guidance. So if I give the same data set to multiple people, they will come up with similar numbers in terms of the response rate. And finally, we emphasize that they are important to think about molecular responses, although those are only recommended at this point as provisional endpoints because of issues related to problems in standardization between different institutions, but also in terms of their association with long-term outcomes. And finally, emphasize the importance of also including patient-reported outcomes in clinical trials. And indeed, those response criteria are being validated. We actually also collaborated with a number of institutions in the US to develop the Validate database, which has patient data from multiple institutions. And it's some of these data, there are multiple abstracts which will be presented in ASH 2023, looking at those response criteria, but also validating the IPSSM and a number of other important clinical questions. So now moving to therapeutics, and I'm going to divide the remaining of the talk into 3 categories. One is focusing on lower risk MDS, the current therapies and the new therapies, then high risk MDS, and then finally discuss efforts related to immune checkpoint inhibition. So for lower risk MDS, the year 2023 was a big year this year because we have 2 positive phase 3 trials that I will discuss. But the overall management of lower risk MDS generally looks something like this. There are different variations of this figure, but generally if patients have low counts, but they are asymptomatic and they're not transfusion dependent, we generally will observe if the patient has anemia that is significant, symptomatic with a hemoglobin of less than 10, especially if they are transfusion dependent, generally the treatment, if they have deletion 5q, is with lenalidomide. If the patient does not have deletion 5q and the EPO level is less than 500, until 2 months ago, the standard treatment was erythropoiesis stimulating agent. But now we have luspatercept moving to the front line. I will talk about this agent and the trial that led to move on to the front line. After ESA failure, we had luspatercept for patients with ring sideroblast, but we also had other things such as immunosuppressive treatment and lower doses of hypomethylating agents. In patients who have isolated neutropenia or thrombocytopenia, which can happen, anemia is the most common abnormality in MDS. For those patients with isolated neutropenia and thrombocytopenia that is severe or causing infection or bleeding, TPO-mimetic for thrombocytopenia or HMA for neutropenia could be considered. So starting with anemia, I mentioned lenalidomide and ESA. Those are standard of care agents. I'm gonna not discuss them today for sake of time, but the Middle East trial introduced the first newly approved drug for lower risk MDS in almost since 2006 when lenalidomide was, or since 2005 when lenalidomide was approved. So luspatercept is a transforming growth factor ligand trap. So this pathway basically is activated in patients with MDS and leads to suppression of erythropoiesis, especially late erythropoiesis. And luspatercept is a protein. It has a modified extracellular domain of activin receptor 2B, and it removes some of those ligands that are focused on receptor 2B, and that leads to restoration of effective erythropoiesis. You can see to the left the top-line results from the Middle East trial that led to the approval of the drug with a transfusion independence rate among patients who had ring sideroblast who were transfusion dependent of 38% compared to 13%. And based on this, the FDA approved the drug. And we have shown in longer follow-up from the same trial that the benefit from luspatercept is not only related to transfusion independence. Actually, many patients, even who don't achieve transfusion independence, will also achieve significant reduction in their transfusion burden. And this applies to patients with lower and higher transfusion burden, but also there's a significant increase in hematologic improvement with that drug. So I think, again, this drug was clearly established as a very effective way to treat patients with after ESA failure in patients with lower risk MDS who need transfusion, regular transfusions. But then the COMMAND study came along, and this trial was finally presented in ASCO 2023 and EHA, as well as being published in the Lancet Journal. You can see the full paper right now available online. The COMMAND study looked at two questions. The first question was, what is the efficacy of luspatercept in the frontline setting? So head-to-head against Epoten alpha, which is a short-acting ESA. And the second question was, what is the activity of luspatercept in patients without ring sideroblast? So this was a large international study conducted among patients who were transfusion dependent with lower risk MDS, regardless of their ring sideroblast status. The patients had to have a lower risk MDS with less than 5% blast and to have a transfusion of 2 to 6 units of blood, and they had to have an EPO level of less than 500. And you can see the primary endpoint of the study was achieving a transfusion independence and a mean hemoglobin rise of more than 1.5 grams per deciliter. And you can see that the primary endpoint was met. To the left, you can see it was 60% compared to 31%, which I think is quite good. It's double the rate of transfusion independence against the standard of care, which was ESA. And to the right, you can see across different subgroups that ESAs did better. That luspatercept was better in every single subgroup. In patients with ring sideroblast, without ring sideroblast, the rate was similar, but the duration of transfusion independence was higher with luspatercept. Another important, and based on the data that I just showed you, actually, the FDA has approved this drug for frontline management of patients with lower risk MDS who may need red blood cell transfusions. and regardless of the ring sideroblast status. Another important drug is imetelstat. So imetelstat is a first-in-class telomerase inhibitor. Telomerase has been shown to be important in the pathogenesis of MDS, and imetelstat targets the malignant MDS clones, which have high telomerase activity. It inhibits them and leads to their death and apoptosis, and therefore recovery of effective hematopoiesis. A phase 2 trial showed very encouraging data, and the emerge phase 3 trial, which was presented in ASH and ASCO 2023, as well as it has been actually accepted now for publication, should be coming out soon, where had a similar design to the Middle trial, where patients were randomized to receive imetelstat versus placebo in a 2-to-1 fashion. Those were lower risk MDS patients after ESA failure, but importantly, those patients had to have 4 units or more of transfusion in the last 8 weeks. So those were heavily transfusion dependent patients, and the primary endpoint was transfusion dependence at 8 weeks. Again, it was a positive trial, very nice data with 40% transfusion independence at 8 weeks, and this was durable. You can see even at 1 year, the duration of transfusion independence was statistically, or the rate of transfusion dependence was statistically better with imetelstat compared to a placebo. And I think very important to note that the mean hemoglobin or the median hemoglobin rise among patients who received luspatercept was quite impressive. Those hemoglobins went from 8 grams to 11.5 grams. So that's a median rise of 3.5 grams, which is much better than the 0.8 that was associated with placebo. And based on this, and of course, the drug can cause cytopenias, but generally it's reversible if you hold the drug, and the more than 80% of grade 3 and grade 4 drug-associated thrombocytopenia and neutropenia will revert to grade 2 within 8 weeks, within 2 weeks of holding the drug or reducing the dose. And this is important because it's reversible and manageable and did not lead to a risk of severe infection or bleeding. And based on this, the drug has been submitted to the FDA for consideration of approval. We're hoping to have a decision on the drug by early next year, 2024. So moving to high-risk MDS. So with high-risk MDS, the treatment paradigm has really not changed much in the last 20 years. The transplant consideration continues to be the most important and the only potential way to cure patients. HMAs have been available as well, but HMAs, they have multiple problems. One of them is that most patients will not achieve complete remission with HMAs, and HMAs, there is no way of predicting which patients respond and will not respond to HMA. And generally, you need multiple cycles, 4 to 6 months before most patients will respond to HMA. So for all of those reasons, as well as real life data, such as what I'm showing you here, that you cannot cure anybody with HMA. So if you give HMA and you do not go to transplant, there is really no tail at the end of the curve. The median, the 5-year survival is 4%. So this is why we strongly recommend patients to go to transplant. But importantly, even at the median level, at the median survival is 17 months in younger patients who go to big institutions, and in SEER Medicare analysis, only 11 months. So clearly, I think we need better ways of treating patients aside from hypomethylating agents, but we have been trying for a long time now. As I told you, multiple drugs have been shown to have potentially good data in phase 1, but once they went to the randomized phase 2 and phase 3, they have been negative. This is a listing of some of those drugs, and the latest addition has been magrolimab. This has been, I think, one of the problematic issues in drug development for MDS, that we have not been able to find a single drug so far to combine with HMAs to improve survival. However, despite all of these failures, there are other promising agents. One of them is venetoclax. So venetoclax is an oral PCL2 inhibitor already approved for AML. Combination with azacitidine has been shown to give good responses with a CR rate of 35%, overall response rate of 80%. But this is in the context of single-arm phase 2 trial. It was across the genetic spectrum of MDS. We have shown an add-on strategy where you add venetoclax to azacitidine after azacitidine failure leads to responses. While some of those responses are more CRs, but there are significant number of patients who achieve transfusion independence and clinically meaningful responses. And indeed, a randomized phase 3 trial called Verona has been fully accrued. More than 500 patients have been treated across the world. And those patients were randomized to receive venetoclax or, to receive azacitidine with venetoclax versus azacitidine with placebo, with a primary endpoint of CR and OS. Immune dysregulation in myeloid malignancies has been also well described both in AML and MDS. We know that transplant, which is immune intervention, is the most efficient way of treating patients with AML and high-risk MDS. And we know that there are many immune deficits that happen in MDS, including dysfunction at the T cell level, as well as dysfunction at the level of the NK and the macrophages. And for that reason, immune activation through immune checkpoint inhibition has been something many of us have been trying to examine in heme malignancies. Some of the early data, for example, from Dana-Farber suggested activity post-transplant failure, where 5 out of 13 patients who had relapsed post-transplant with AML achieved responses, complete response, and it was mostly in extramedullary disease. We tried to take that in our own hands in HMA failure setting, where we gave ipilimumab, the same anti-CTLA-4 that was used in the Dana-Farber trial. 29 patients were enrolled in a CTIP-sponsored trial. This was an investigator-initiated trial in 6 centers. There were immune-related adverse events, but generally they were reversible and manageable with dose interruptions and steroids. However, we did not see significant clinical responses, but we did observe that patients who went to transplant did not appear to have excessive toxicity. And we did extensive correlative testing to try to correlate responses or clinical benefit in terms of stabilization of disease with some biomarkers, such as increased frequency of ICOS, which is a co-stimulatory marker. But other markers, such as commonly used in solid tumors in patients who get immune checkpoint inhibitors, such as peripheral T cell receptor diversity, did not correlate with clinical outcomes. We therefore took this to the, try to do randomized trials, because some studies suggested good benefit in single arm studies, but there has been a lack of randomized clinical trials. This is the first randomized clinical trial of immune checkpoint inhibition with durvalumab, where patients received azacitidine plus minus durvalumab. Patients both with MDS and AML were accrued on this trial. More than 210 patients were treated, and there was no difference between the 2 arms, as you can see in the overall response rate or in the overall survival, progression-free survival. This was disappointing, and we tried to understand why is that the case. We did not see reduced exposure to azacitidine as a result of the combination, which was a concern. We also did not see an impact on global DNA methylation in the combination arm. So neither of those possibilities accounted for why there was no increased clinical activity. Another possibility we looked at was increase in expression of PDL2, but that also was not seen in our samples, suggesting that increased expression PDL2 was not bypassing PDL1 inhibition. And finally, and this was actually surprising, is that we did not see any activation of the immune system in terms of T cell expansion in the blood or the bone marrow, despite the use of durvalumab in the frontline setting in this trial. So this probably explains why we did not see clinical activity. And finally, we tried to look at subgroups. We looked at patients who have TP53 mutations and patients who have splicing factor mutations based on retrospective data or preclinical data suggesting those patients might benefit more from immune checkpoint inhibition. But in these analyses, which have been presented and some of them published in the Leukemia Journal, we did not see any difference, including by hit status, and those analyses were led by Dr. Jan Beversdorf, who will be joining Yale next year. And because of all these failures in combination with HMAs, we tried to look for other ways to combine. So one way to combine was with entinostat, and this was based on nice preclinical data in solid tumors as well as in MDS, suggesting that myeloid-derived suppressor cells can mediate resistance to immune checkpoint inhibitors, and in murine leukemia models, myeloid leukemia models, adding entinostat, which targets myeloid-derived suppressor cells, seemed to synergize with PD-1 knockout, and those mice had the best survival. Based on this, we took this to a single-arm phase 1b study of combination of pembrolizumab with entinostat, and this study took place in multiple centers. We enrolled a number of patients. The clinical data were unfortunately negative, and we are currently trying to understand that by doing a full analysis on the correlative samples. However, there are more exciting immune checkpoint inhibitors. One of them is TIM3. So TIM3 is expressed on patients with acute on T cells, but also on leukemia stem cells and blasts, and therefore targeting it not only can lead to immune activation, but also it can directly kill the leukemia blast, and could be a bifunctional mechanism of targeting. Nice preclinical data and early phase clinical data led to a randomized phase 2 trial, which I'm showing you here. We presented the data in ASH 2022. And this trial included 17 countries, more than 127 patients were randomized to receive HMA with sabatolimab versus HMA with placebo, with a co-primary endpoint of CR and progression-free survival. The primary endpoint was not met, unfortunately. The CR rate was similar, but you could see that there was a trend for improvement in PFS with 11 months compared to 8.5 months with late separation, suggesting that there could be a delayed onset benefit, which is something that has been seen with other immune checkpoint inhibitors. And importantly, the duration of CR was longer. It was double the duration of CR among those who got monotherapy, 18 months versus 9 months, suggesting that the combination might have deeper responses in patients. And based on all of these data, we have a fully accrued randomized phase 3 trial called Stimulus MDS2, which compared patients who received azacitidine with sabatolimab versus patients who received azacitidine with placebo. This trial is fully accrued, and we are expecting results early 2023. Early 2024, and hopefully, again, if this trial is positive, it will change the landscape of management of MDS. In the last few minutes, I'll talk about some efforts also in AML and immune checkpoint inhibition. We have a randomized phase 1 study that is ongoing with CTIP, where patients receive 7+3 plus minus pembrolizumab, focusing on a primary endpoint of MRD negative CR, being led by myself and Dr. Rory Chalice under my mentorship. And we have also PLAST AML2 study, similar study, but uses aza-ven plus minus pembrolizumab with a similar primary endpoint. And we are doing MRD assessment by flow cytometry with Dr. Brentwood as the primary endpoint, but we are doing extensive analysis of MRD using circulating tumor DNA, as well as next-gen sequencing and duplex sequencing, to try to see if we can achieve deeper responses even at the leukemia stem cell, and a large number of correlative testing that are being done through the CMAC, which is the Cancer Immunomonitoring team at CTIP, looking at things such as cytokine changes, as well as whole exome sequencing, RNA sequencing, and T-cell receptor sequencing, and DNA methylation, and immune cell subset analysis, again, to try to correlate any responses or toxicity that we see within these trials with correlative changes. And lastly, we have PLAS-3 study, which is going to include IDH inhibitors in combination with pembrolizumab. This will be an IIT run at Yale at Dana-Farber. And we have a triplet with sabatolimab, aza-ven, sabatolimab, This is fully accrued 86 patients. We reported safety results in EHA 2022, and hopefully we can have the full set of results in 2024 as well. But we have already shown that delivery of immune checkpoint inhibitors can be done in a safe way to myeloid malignancy patients. Immune-related adverse events are seen. There are issues related to being able to do biopsies because of the low platelet count, or give steroids because of risk of fungal infections. But generally, it's feasible, it's doable, but it requires expertise with experienced investigators and to be done in centers that have experience with use of immune checkpoint inhibitors. And lastly, I think using a biomarker-driven approach where you look at signatures that could predict response, for example, this immune effector dysfunction signature might be important rather than to just put all newcomer patients on these clinical trials without any prior selection. And I think this is something that will probably have to be implemented prospectively to hopefully find finally find the immune checkpoint inhibitor that will lead to benefit in patients. At the end, I like to thank the Leukemia and Myeloid Malignancies Program at Yale. We have a very vibrant team, and we see a lot of patients, as well as our clinical research team and all the organizations that funded my research. This is my Twitter or X, I guess, handle, as well as my email. And feel free to reach out to me for any questions. Thank you so much.
Thank you so much, Doctor, for the wonderful presentation.
Sure, my pleasure. You see here.
Yes.
Yep.
We know you're definitely short for time, and we'll try to keep this as concise as possible. But honestly, this was really interesting. I did not realize that there was so much information we did not know about MDS that I truly learned today as well. Over to you, Ms. Khan.
Thank you so much, Amer Zeidan, for that wonderful keynote presentation. It was truly a delight. As Madhuri just said, it was truly a delight listening to you. And I'm sure our listeners had a lot to learn and had a lot that they have a question, that they have many questions to you about, for sure. So I will now be passing over the mic to Viviana, who's our moderator for today, and she will be leading the remainder half of the session, the Q&A portion of the session. So over to you, Viviana.
Thank you very much, Madhuri. So thank you for coming and welcome to the discussion with global leaders. So I am Viviana Cortiana, and now we are excited to be speaking with Dr. Zeidan. Particularly Dr. Zeidan, as we know, is from Yale Cancer Center. So we have received a lot of questions, and we will try to do our best to get through all of them in time that we have. So for the first question, actually, I would like to ask it, if possible. So I would like to ask to Dr. Zeidan if you think that in the future oncology and immunology could work in synergy towards the research of a potential new treatment for cancer and specifically for hematologic malignancies.
Yeah, I think that's certainly the way things are heading. So I only covered immune checkpoint inhibitors in my talk, but of course there are multiple ways of targeting the immune system. We all know about the revolution with the CAR T cells, the chimeric antigen receptor T cells, that have been very effective in B-cell malignancies and now being tested in not only in blood cancers, but also in a number of solid tumors. And there are other immune cells that are being used, for example, the NK cells as well. There is also the bispecific antibodies, which delivers basically the T cells to the cancer cell, and those also have led to improvement in several cancers and several approvals. For example, we have blinatumomab in MDS, in B-cell ALL, and there are a number of in multiple myeloma as well as in other cancers. And there's of course antibody drug conjugates, which uses an antibody to deliver immunotoxins or potentially, to deliver chemotoxins or potentially other toxins or radiation to the cell. So I think there are a number of factors that are kind of will lead to increased synergy between immunology and oncology. Immune checkpoint inhibition has revolutionized solid tumors, of course. There are many indications for those immune checkpoint inhibitors, but in blood, in particular myeloid malignancies, MDS and AML, we're still trying to explore that potential fully.
Thank you very much, Dr. Zeidan, for your reply. It's very interesting, and I also do believe that these two subjects, immunology and oncology, have a great potential by working together. So thank you for your reply. I'm not going to be passing the microphone to Alex. Lexi, we should have a question for you. So Lexi, feel free to ask your question if you wish.
Hi, Dr. Zeidan. Thank you so much for this really insightful presentation. It's very apparent that this field is quickly changing and we're seeing immense advancements. So I was wondering, what are you most excited for in the future of this field?
Yeah, in particular, I think in MDS, we have done a lot of work with this antibody sabatolimab. I think we are excited to see the results of the phase 3 trial, which will be reported hopefully by early 2024. Of course, there is a large number of other immune checkpoint inhibitors, and there was a lot of excitement about CD47 targeting agents, but unfortunately, magrolimab, which was the first-in-class CD47 targeting agents, which works on the don't eat me signal to activate macrophages. Nice early phase data, but unfortunately there was a press release that the phase 3 trial was negative. But there are a number of other agents that work on this pathway, including CD47 and SERP alpha. So I think it remains to be seen how this pathway will be important in development of new agents. And as I mentioned, there's a number of bispecifics, CAR T cells, etc. So I do think the future hopefully will be looking quite good for patients with the myeloid malignancies.
Thank you.
Thank you very much for your reply, Dr. Zeidan. So now I'm passing the mic to Ahmad.
Hi, doctor. So my question for you is, doctor, so what advice do you have for patients who are suffering from myelodysplastic syndrome, and for what are the best possible things they can do to maintain the quality of life while suffering from this?
Yeah, I think the most important advice, in my opinion, is to make sure they see an expert who has knowledge in MDS, because there have been a lot of moving parts, as I showed you, in diagnosis, in classification, in response assessment, but also new therapies, clinical trials, to make sure that transplant is being discussed. So for all of those reasons, for example, in the US, many of the patients are seen at the community level. And because MDS is relatively rare, many of those doctors might not necessarily have the full scope of what's going on in MDS. So I always encourage patients to ask to be seen by an expert in the nearest big center. Now we have telemedicine, other ways where patients could potentially be seen even if they live far from a big center.
Right. Thank you, doctor.
Sure.
Thank you very much, Dr. Zeidan. So now I will be passing the mic to Rabab, who will be asking our last question for the day. So a huge thank you to our speaker for this amazing session. Thank you also to you all for the great questions, and to all of our attendees. And please, of course, continue to follow MedNews Week on all our platforms, and be sure to catch the replay.
Thank you, Viviana. Hello, doctor. So thank you for the amazing presentation today. It was really intriguing. So my question to you is, for our more junior attendees just getting into research and medicine, what inspired you to pursue the field of hematology-oncology? And how has this choice impacted your life? Like, has it been everything that you had initially anticipated?
Yes, that's a good question. I think it's for me personally, it's something I always wanted to do since I was in medical school. I went to medical school in Jordan, where clinical medicine is very good, but there are very limited research opportunities, like I assume for many of you. So in order to pursue clinical research, you really had to kind of move out of the country to Europe or the US or other kind of more advanced countries. And this has been the biggest, I think, challenge that I had to go through. I suspect many people are also having to consider this as they move in their careers in medicine, if they are interested in doing kind of clinical or even translation, any kind of research most of the time. So biggest advice, I think, is to kind of know what you want and try to work very hard for it. I always say that medicine is a life choice, and it's a career. It's not just a work. You can't just go at 8 and go back at home at 5. It unfortunately or fortunately, depending on how passionate you are about what you do, it tends to stick with you on many times in the evenings. You have patients, you have you have your academic work, and on weekends, etc. So I think people have to kind of think carefully about what they want, and make sure that they have kind of the stamina and the motivation to kind of do this so that they can be successful.
Thank you so much, Doctor.
Yeah, thank you so much for all of you, and thank you for MedNews on the kind invitation and all the great questions. And for those who wanted to ask but did not get that chance, please feel free to reach out directly. And thank you so much. Hope to see you again, and maybe in person in the near future.
Thank you, Doctor. Thank